with today's presentation. As you can see, question number 1 is a communication station. It requires a simulator. So Dr. Alhati have agreed to simulate while Dr. Becky will proceed with the question. Welcome, everybody. Thank you. Dr. Becky can start, please.
Good morning to our teachers and everyone present. I'm Dr. Becky. I'll be taking practice question 11 of the November 2022 practice question. The question reads, counsel a 25-year-old house officer who was found to have 4 cysts in each kidney during a routine screening. His father died from a stroke. Serum creatinine level was 188 milligram per dl. Address his concerns. Sorry, my slide is not moving. Okay. Okay, good morning, doctor.
Good morning, ma.
Okay, I'm Dr. Becky. I'll be discussing with you on the reason why you are here at the clinic today. Hope that's fine.
It's okay, ma.
Thank you very much. So, yes. Sir, I would quickly, so I don't know if you came with any person, a relation or a friend to the clinic, or you came alone?
No, I'm alone, ma.
Okay, so would you want to go ahead with the discussion alone? Or...
No problem, I'm okay.
Okay, I hope this office is fine by you, or you want us to move somewhere else?
No problem, ma. You can go ahead.
Okay, thank you very much. Please, in the course of the discussion, I would be asking you some information, including some personal information. Hope that will be fine by you.
No problem, ma.
Okay, please, what's your name, your age, your tribe, and religion and address?
My name is Dalhatu. I'm a 25-year-old. I'm Hausa.
Okay, where do you live, please?
Okay, I live at Kano.
Okay, thank you. From the documentation here, it shows that you are an arts officer.
Yes, ma'am.
Okay, you are welcome, sir.
Thank
So,
you.
From what I have here, it shows that you came for a routine check, and then you did an abdominal scan and some blood test, and you are here to know what the results state. Is that correct?
Yes, ma'am.
Okay, so I don't know if before now you've heard or you had the opportunity to know what the results stated.
Yes, the doctor was explaining some things to me, but I'm not comfortable with him.
Okay, so please, can I know what the doctor explained to you, and if you have any concern or idea or expectation about what you heard?
Yes, he said I have cysts in my kidneys.
Okay, do you know what that means?
Well, what they taught us in medical school, there are a lot of issues with me, and I'm not actually interested.
Oh, okay. So what would you want me to inform you or educate you on about the results that's of the test that you did?
How can they say I have this cyst in my kidney? The trauma of my father is still with me, so I'm not interested in those things. But
oh, sorry about that. Sorry about your Sorry about your loss. Okay, so please, can I go ahead to tell you about this, because you just might not know that what this result is stating may be linked to the reason your father died. So it may be very important for you to be aware and probably take preventive measures or manage the situation better. I hope that's fine by you, sir.
You have spent 5
No,
minutes.
no
You have 2
problem. You
minutes
can
more.
go ahead. Oh.
Okay, so the result says that you have cysts, 4 cysts in each of your kidneys, and that means that you have a condition called adult autosomal dominant polycystic kidney disease. And even the blood test you showed, you did show that the creatinine level was elevated. And this condition, it's a genetic condition that occurs following an abnormal gene that is inherited from either the father or the mother.
Why is it only me? Why not my other siblings? Doctor, why should it be only me?
Oh, so in the course of this discussion, I will explain more on how the chance of having it occurs and why some family members may have and some may not have. Okay, so maybe I should quickly just address that. So it's a genetic condition that is inherited in the autosomal dominant fashion. It means that an abnormal gene, I don't know if you recall what genes are. So genes are like the building blocks of what forms structures, tissues, and organs in the body. So when there is abnormality in that building stage of it, it can reflect on the function and probably structure of the organs that of the particular organ that is supposed to be formed. So in this situation, this gene is expressed majorly in the kidneys, but in other structures of the body. So when it's abnormal, it can result in formation of sac containing fluid that we call cysts. So they are like nylon with water in them, containing cysts formed from the tubules of the kidneys. And because of the presence of this cyst, it can over time crowd out the normal nephrons, and that could result in
Man, me, I cannot die now. Oh, I'm not ready to die now. This one that you are blowing these grammars, man. I'm sorry, oh, please.
Sorry, sir. Having this condition doesn't mean that it's a death sentence. About 50% of persons.
It's already time. It's already time.
Okay, sir. Should I please continue?
Hello? Just allow her to round up. Okay.
Okay, sir.
Thank you, sir. So about 50% of persons with this condition may live without having symptoms, even up to the time they pass on. So it doesn't mean that it's a death sentence. Okay, so but I will just quickly just tell you the symptoms that can occur from this. So from the kidneys, you can have kidney failure because this sac containing fluid may kind of occupy and displace the functioning nephrons, and that could impair the function of the kidneys. And it can occur in other structures, but not the occurrence rate is lower compared to presence in the kidneys.
So my only kidney is so the whole of my body will get swollen.
No, it doesn't mean that. It's just a possibility that it could be. But one thing I want to assure you is that you can be you've come to a specialist center where you'll be fully and holistically evaluated for these features, and if there is any, be rest assured that you have specialists that could manage the situation. So going back to your concern, your initial concern of why just you and not your siblings, we can't for sure to say that your siblings are not affected, but there are investigative modalities that would help to check if your siblings also have this condition. And pertaining to the fact that you were concerned that your dad died earlier, not so long ago, from a stroke, there are many causes of stroke. One of them is this condition. If the mechanism with which this the pathogenic mechanism with which this disease occurs happens in the brain.
So it's not that I'm going to die peacefully, ma. I will go into have stroke before I die.
No, sir, I didn't say that. I didn't say that. Having this condition does not mean that you have stroke. Just about 4 to 10% of persons having this condition may have what we call intracranial aneurysm in the brain, and that is a risk factor for stroke. Even with that, not everyone, about 50% of these persons don't even have rupture of this aneurysm, which is like dilatation of the vessels in the brain. So don't even have rupture that eventually will lead to stroke. And not everyone who has stroke will just die from stroke.
Doctor,
and there are many causes of stroke.
Doctor,
I
think you better stop this discussion. You are just making me too depressed. All the bad things are happening to me. Ma, I'm not interested, please,
Okay, I'm sorry I'm making you feel this way. Probably we would reschedule this discussion if that's fine by you, sir.
I'm even getting worried by coming to our office, please. Ma, I'm not coming to our office again, please.
I'm sorry, sir. I'm sorry, sir. I don't know if we could stop the discussion since he's no longer interested.
How about doctor? Round up now.
Okay, sir. So that's the so one thing I want to assure you is that we would examine you. So features like if your BP, because this can cause high BP. If you have BP, high blood pressure, would manage that.
Not interested now.
Okay, so sir, I would want to give you tracts that you could read more about the condition so that you'll be more aware, because you are a medical personnel and you know that when a condition, there is a genetic condition, it has different penetrance and different way of expressivity. So having the condition does not mean that you would express the manifestation. So even if your siblings have the conditions, for example, which would evaluate for, because there are genetic testing for that, even the ultrasound scan and other investigative modalities are available for us to evaluate them. And for the risk of stroke, we have a magnetic resonance angiography that would advise that you do. That would help to exclude the risk of intracranial hemorrhage. So I'll give you trust that you can read more. And if you have any question or clarification, you could come to us. You could see me or any other doctor so we could address them. I don't know if that's okay by you, sir.
Okay.
But by and large, I want to please just end this discussion by letting you know that having this condition is not a death sentence. It's a condition that can be managed, though it cannot be cured. But coming to a place where you have specialists, it can be managed with medications, and if there is complications, there are even interventions that could be done to help manage those complications. I hope that's fine by you, sir.
Okay, ma.
Thank you very much, sir.
Thank you, ma.
Okay. Thank you, Dr. Becky, for good counseling, and thank you, the simulator, for making it so dramatic. So as usual, the floor is open for contributions and comment from us before our teachers come in, please. Well done, Dr. Becky. I just want to, I think it's a good one actually. In this kind of thing, we expect you to invite the patient to recap at least twice. Maybe having halfway, okay, so far, can you recap what I said so assess whether he's getting what you said. I think that would be better, recap. Yeah.
Yes, sir.
Thank you. Well done.
Okay, good morning, everyone. Good morning, senior colleagues and colleagues. Okay, Dr. Becky, you did a very great job. But in the aspect of empathy, I didn't, it's not really a good story you're breaking to the patient. So empathy, I didn't really feel it. Then again, to the consent of the patient, because most times they have questions, they have worries that could actually attract marks for you. So in between, I think you should have been asking, do you have any concerns? And, in this exam, it's what attracts marks that you're actually looking out for. So I didn't really hear you asking him of his concerns. Then again, at the beginning, okay, I was actually disrupted. I don't know if you asked him of his perception, what he knows about his disease condition. So yeah, so that's what I think you actually missed out in your spikes. The empathy wasn't there. Then his concerns. In between, you should have been asking him of his concerns so that you can actually pick up your marks from there. Then lastly, I don't know if you asked him of his perception. And again, as what Dr. Yahaha said, you should have done a recap of the entire thing, like introducing and then telling him to recap what you just said to know if he got everything that you explained to him. Because the most important thing is what he is taking home. So that's what I have to say. Thank you so much.
Thank you.
Thank you for your
ma'am.
contribution. Thank you. Chief Ekele is raising his hand. Go ahead, sir.
Okay, good morning, everyone. Thank you so much for the presentation. Okay, I just wanted to also add, I don't know if correct me if I'm wrong, as part of summarizing, because I said his creatinine was 188. Wouldn't it have been nice to say, okay, as part of your management, I'm going to refer you to the nephrology clinic where you'll be on follow-up because your creatinine is deranged. I'm going to do an MRI for you to check if you have maybe any cyst in the brain or maybe, scan other parts of his body, as a way of rounding up, offering some form of management for him, maybe telling him you're going to be on follow-up in nephrology clinic and, something like that. Thank you.
Yes, ma'am. Thank you very much, ma'am, for the contribution.
Sorry, let me just try and respond. If you had followed this discussion, you see that the patient was actually a bit difficult. Okay. So, and already he was saying he was not interested. Somebody that was already anxious about you are now talking about sending to nephrologist. So fine, they are good suggestions, but you need to kind of tune in to the condition. You're not talking apart from, as in you're discussing with somebody and you need to follow their mood, their desires, what they want. There's a particular point that the best thing to have done or to have been done at that point was to reschedule another appointment, because it was obvious that it was not in the right state of mind at that point in time. Okay. However, there are other ways of handling it, and I just felt she didn't handle it very well. Okay. Maybe let me just make my comment at this junction then. Fine. Actually, it was a very good attempt. I like the way you started. You started very well. The only problem was the patient, actually, or the simulator. You were not ready for how he was going to come out for his responses. In fact, sometimes you looked shocked. You sounded shocked. And I really enjoyed it because there are many times that these are the kind of candidates they will bring to you. They want to see how you can handle difficult patients. Okay. So I think the first thing was I felt you didn't create enough rapport. When you started, the way you reeled out your questions, what is your name? Where do you live? What's your, there were so much, and it was so impersonal. You understand? If I was there, why would you have to reel out questions there? That's one after the other now. You gave him like 4 or 5 questions to answer at the same time. What if he doesn't remember some? Okay, so just ask him one after the other. And when you ask for his own name, introduce yourself too. Give him your name. You can even go ahead and ask him, you're my junior colleague, or how I hope med school wasn't difficult. Things like that. I hope your house job has not been difficult. Can I call you by his first name? So maybe if you had created a better rapport, although sometimes you don't know the patient that will be a difficult patient. But if you had created a better rapport, he might have been more cooperative. Okay.
Yes, sir.
That's one. Then, if you notice, anytime you say, in fact, at the beginning, he said he wasn't even interested. At the very beginning, I was like, I'm not interested. Okay. So
Yes.
now, when he said he was not interested, you were still saying, should I tell you? Someone said he's not interested. So what you could have done at that point was to ask him, okay, so you are here now, sir. What do you want us to do? What's the way forward? Okay, actually have your results. I can give you your results. I have good news but I also have bad news. Which one should I start with? You know, those are the ways to talk about it. And he will now respond and say, okay, give me the good news first, or give me the bad news first, whichever. Okay, so if you do that, it's unlikely for him to say, I'm not interested at all, after he has said, give me the good news, give me. So he'll be waiting to hear the good and the bad news. So you'll be able to tell him some of the things you want to say. Okay, and then it is during that point that you can start asking about recapping. Okay, don't worry, I know the news I have for you is very bad. I'm sorry about that. I'm sorry. Those are the part of the empathy that someone brought up, that they didn't see you show a lot of empathy. I think you were so interested in delivering what you know about the disease condition. Okay, mind you, if you even missed out something, the fact that no other person in his family, maybe they have even done scan, they have checked, and he's saying he's the only one. Is it not possible? It's possible. You know, there are very few cases of spontaneous mutations that can lead to ADPKD. Okay, it's possible. Okay, so those are the kind of things. So, oh wow, I'm so sorry about this. You are the only one. Okay, it's actually possible. Maybe there is a spontaneous mutation. You know, things like that. However, you can now, mind you, the fact that the father died of stroke does not translate to the fact that he had barium aneurysm. It's not compulsory that that's what happened. Anybody can die of stroke if you had hypertension and stuff, okay? But later on, you can try and say maybe, because maybe they want you to link it, fine. But he has just told you that no one else in his family. So you have to know that there's also a possibility that it can occur spontaneously, okay? Now, when you're now talking about management, the first thing or the complications, you just went straight to kidney disease, to CKD. You could have started from the initial things that can happen, like hypertension. You can ask him, do you have hypertension? And he said, no. Okay. All right, we need to monitor you because one of the earliest signs is hypertension. Okay, so we need to check so that if that happens, if we can catch it early and treat it, it can reduce the progression of the disease, you know. But you just went straight to CKD. The minute you say CKD, the man say, God, I'm dead already. Okay, so gradually you give the information. Okay, so and then you need to know how to manage this kind of patients. There's a way, the way he shouts, and you would need to calm down, relax, give him some time. Oh, so I'm so sorry for giving you this bad news. I'm so sorry. I'm so sorry. Don't worry about it. I will do our best to make sure that you get better. Okay. But the man is shouting after one bad news. You have not given him any good news. You are giving him more bad news. Hi. Before you know it, you now start talking about stroke. You say, people going to die badly. So, okay, so it's actually, sometimes you might not even have so much time, but I think there's enough time if we do it the way you should. Okay, so but please, I like this kind of candidates, this kind of patients. You can see it in the example. They will just tell the simulator not to give you any information. And like they have rightly said, you have to be asking for consents too. Very important. The patient might have like 6 consents or the simulator, and they will not give you any until you ask. If you ask, they will give you 1. When you finish addressing that consent, you need to ask again before they will give you another one. And they will be told to do that. Don't tell them all the concerns at once. Just be giving them 1. If they ask you for a consent, give them 1. When they have addressed it, if they ask you, give them another 1. Like that. So it happens like that in the exams. Okay, so, but well, you actually started well and you had your stuff. It's just that you met a candidate that threw you off balance. Okay, so I think that's what I want to say. You can go ahead.
Thank you
Thank you,
very
sir,
much.
for this
Dr.
contribution.
Yaya,
Yes, ma'am.
Dr. Yaya. I just want to quickly make a comment just after our dear Chief Remigo says what he said. Please, Dr. Dahatu role was just perfect. I don't know, it's as if you are simulated before. That was perfect. In fact, I don't know what to say again. Besides, I don't know what word to use beside perfect. That is how it is. And in that exam, we managed, we referred to nephrologists. Do you understand? I just believe that's why we say let's practice more of these things. Reality and exam are two different things. Just imagine if your colleagues can throw your balance like this. Just imagine how it will be in exam. So no matter what, learn to be, it's not the number of stuff. They are not after the stuff you are moving. They're after how do you interact with your patient. He's your colleague. There's a lot of, you understand? You understand, this is your colleague. There must be a rapport. It's how your patient, the more your patient is shouting, you want to kill me, you calm down, no, and say, sorry, please, how do I explain it again? Do I explain it this way? There was a lot of ekbele in that station. Oh, sorry. And I remember that particular station, the examiners were coming to make sure that the simulator was as mean as possible, checking their faces, making sure that all they were told to do, they were doing all the right face, the right everything, and nothing was being given away. So, but Dr. Fatima mentioned that they're trying to move away from simulators already, but irrespective of what they're going to throw at you, know that they can throw anything at you. And most time, they don't bring nice. It's okay now. They don't bring nice simulators. They do not bring nice simulators. And the examiners occasionally come, especially those rooms that are simulators. It comes to make sure that they are behaving the way they should behave. Because most of them are doctors, really. So once in a while, you see them trying to give you signs and they're trying to just do one or two things just to encourage you. And if you're in the right track, you see them give you sign that you're in the right track, all of that. So the examiners come to make sure that all of that, nothing like that is happening. So I just want to say that Dr. Dahatu was just perfect. So when you see people, cases like this, try to be as emphatic as possible, try to be as nice, don't rush to deliver all this stuff. That's not what they're after. They want to see what would you do in real life. You just want to deliver and go. You don't even care the patient understand on, you just want, no. They want to see how you handle it. So you might just be amazed. You might not even move so much stuff, but you end up calming down your patient is happy, you are happy, you have passed. You have just passed that station. So please, I think we should let it be more patient-oriented than we, the doctors-oriented. So we can continue. I'll make more comment later.
Thank you very much, ma'am.
Thank you, ma'am. Dr. Chidima. Go ahead, Dr. Chidima.
Good morning, my senior colleagues and colleagues. Sorry, my Chief Remigos has said everything that I wanted to say. Sorry for not putting it. Thank you.
Thank you very much. Any other thing, please, before we move to the next presenter?
Hello, good morning, Dr. Yaya.
Good morning, sir. You're welcome, sir.
Yes, so sorry to take you back a bit. Okay.
Yes, sir.
Yeah, so I just wanted to point out something, okay? Your communication and how you communicate effectively with the person that is simulating with you is part of the things they are assessing. And it's a major part of the mark, actually, okay? So they expect you to communicate with the person according to what has been put before you. So it can be, in this case, the house officer. So they're expecting you to create some rapport. Oh, house officer, what posting are you in? Okay, how is it going? And all of that. What school did you finish from? Things like that to create some rapport. Then when you're taking your biodata also, they've already given you some stuff, all right? They've told you that the age, they've told you what the person does. So all you have to do is confirm those things. Oh, I understand you're 25 years old. The answer would be yes. Oh, I understand that you are a house officer. The answer will be yes. Do you understand? So you don't have to start asking the person, oh, what's your age? What's your all over again? It's like almost wasting your time, so to speak. And the time is not very long. And then also it's not proper to ask for the person's concerns. You're supposed to tease it out. Back in the old days, they could fail you for saying, sorry, what are your concerns? you are supposed to tease it out. When you deliver your knowledge of the particular disease entity, and the person is giving you feedback on, the things you've told him and everything, okay, right? Then you cannot ask, do you have any further questions about these things I've told you and things like that? And it's prompts like that that would make them mention the concerns, if there are any. Okay, so you must be seen to have a back and forth with your patient, okay, trying to get all the information about the issue. And then also be sure that they have the right information, they've obtained the right information from you as well. Okay, I think Dr. Remigos had covered most of the bases. And of course, please show empathy. Okay, as Dr. Christabella has pointed out, look, National, I don't know where they get their simulators from, but they are not nice. I don't know if they train them to be like that. I suspect they train them to be like that, but they are not nice.
They train them.
So they don't give away anything, and they've been told not to say certain things unless prompted accordingly. Many a time you see them looking at their examiner. The examiner will give them the go ahead to tell you. Maybe you find out if you've said it okay. Then the person will look at the examiner. Examiner will be like, okay, go ahead, tell him. Do you understand? So they are prompted by certain things. And many a times you can take them off guard. And it all boils down to how well we communicate with our patients normally. Okay? Me, I'm the type of person that I like to make, when I'm counseling or talking to you or whatever, I like to break the ice. So many a times, I may say something that may sound a little bit, funny on the other hand, on the other side. Kind of like this particular thing now, when you talked about house officer, you say, what posting are you in? Be like, medicine posting. Say, yay, medicine posting. Man, that's a tough one, and things like that. So the person will be like, yes, so it's tough. Don't worry, you pull through now. We've done it before. Somebody will do it again. That kind of thing. And you kind of like break the ice with the person, and the person is a little more at ease to give you the information, and things like that. These are just what I just wanted to add. Let me not take off too much time. Well, well done, Dr. Becky.
Thank you very much, sir.
Thank you, sir.
All right, so thank you. I just wanted to add just one more thing, okay? The patient is in denial, all right? I think it might be okay to start with saying that, this is an ultrasound scan report of 4 cysts, okay? We have seen, and you remember the ultrasound scan is actually user-dependent, operator-dependent. Okay, so you can actually give the house officer some hope, which is actually very true. You've not said anything wrong by saying that, well, actually the truth is ultrasound scans are operator-dependent. It might be worthwhile to repeat it to be sure, or to go for a better investigation modality if you can afford it, like a CT scan. Okay, but we can also repeat it, making sure that it's now a more senior person that does it. However, if what we got is correct, then what it suggests is this. Okay, so he's a house officer. He knows that what you are saying is true, that ultrasound scan is operator dependent. So there's a possibility that could have been a mistake. Some people can see dilatation or fullness and start saying that seeing cysts. It's possible. Okay, so that could, kind of soften his stance, and then he will now be more willing to listen to you. Okay, and we have done it before. There are sometimes we see ultrasound scans like, this thing is not really in keeping with this patient. I beg, let's repeat the scan. It has been done severally, and sometimes you see something entirely different. Okay, so that's because it's in denial.
On the other hand, 4 cysts on each kidney, the chances of it being wrong.
I know, just to make him feel better.
You can make the patient feel better in so many other ways now. You don't have to say something like doubting your radiologists now. I would say yes, it's important that we confirm it, yes. Okay.
Yeah.
But all
Yeah,
the same,
maybe that's the better word
yes,
to confirm it. Yes.
you can
Thank you.
confirm it using some other investigations, but based on the merit of what we have in front of us, then we can discuss
Yeah,
that.
I think that the way you put it is much better now. Yes, thank you.
All right, you're welcome.
Thank you, Saz. Thank you, Maz.
Okay, thank
So
you,
Dr.
teachers.
Dr. Becky, just surprise. I think everybody has said everything. I just want to emphasize the need for asking your patient to recap. I think in this particular station, I think I asked the patient to recap up to like 3 or 4 times. And in one of those times, he said something that I said that did not make sense. I said, is it me that said this thing? Just quickly corrected. I'm so sorry about that. That's not what I meant to. This was what I meant. Quickly. Just imagine if I didn't ask him to recap. And maybe I changed it. I noticed this. I marked something. So all the points everybody raised, the participants, the facilitators, they are all important. These are things to make you better, not to say, you didn't do well. You did well. But let's not keep praising you and go for exam and you can continue doing what you're doing. We want to polish you so that you get better. Once you go for the exam itself, no matter what they throw at you, you are willing and able to do it properly. Overall, thank you so much. Thank you. Dr. Yahaya.
Thank you, Ma.
Thank you, Ma. Thank you, teachers. I think we move to the next presenter. Dr. Lawrence Ade is going to present question number 12 and the last question for this question paper. Dr. Ade, you can share your slides, please.
She might have to stop sharing her own.
Yeah, Dr. Becky, can you please stop sharing your?
Thank you, Saz. Please, how can I do that? Sorry. Okay, thank you.
Dr. Ade, we are no longer seeing your screen.
Oh, we are not seeing it?
We were seeing before, but we...
Okay, let me reshare it then. Are you seeing it now, Dr.
Yeah, we can see now. I can see, sorry. I don't know whether other people.
Okay. Good morning, my senior colleagues and my colleagues. My name is Dr. Ade. I'll be attempting to answer the practice question number 12 for November 2022. And the questions is a 45-year-old female with multiple small and large joints pain, swelling, and joint stiffness that lasts the whole day, and a swelling on the extensor surface of the left elbow. That was the scenario. So the questioner said, question A is list 5 differentials and defend each. What is your diagnosis? List 2 serological tests you will order for this patient, and if you classify disease edemas with examples. So I will attempt to answer it like this. First on my differential, I think the patient may likely have rheumatoid arthritis. Reason being that the patient is 45 years old, and epidemiologically, rheumatoid arthritis is common between the age of 40 to 60 years. So if she falls into the age range of those who commonly have rheumatoid arthritis. Being a female also, because rheumatoid arthritis also is common among female, and it has multiple joints. The rheumatoid arthritis affects usually start with the small joints of the hand, and it can equally affect the large joint also. And you see the patient has a swelling on the extensor surface of the left elbow, which might be maybe it's rheumatoid nodule. So, and it has a joint stiffness. But the joint stiffness in rheumatoid arthritis is usually commoner in the morning when the patient is at rest. It might not necessarily last for the whole day. But the scenario said the stiffness was for the whole day. SLE is another good differential, but it's a female, and it has SLE can affect multiple joints with pain and swelling also. I think of you only have psoriatic arthritis also, because it's a good differential. However, the patient might have some changes on the nail, maybe like onycholysis, so didn't mention it, and might equally have many joints can equally be affected also. I may have some skin lesion also, typical of psoriasis. Osteoarthritis equally be the differential in this case because of the age also. It's already a middle-aged person, and it's a female too. It's commoner. You can see osteoarthritis more common among females also. And moreover, they say the joint, both multiple joints. Osteoarthritis can affect small joints of the hand also, and the large joint of also maybe probably knee joint. So the diagnosis, I go more of rheumatoid arthritis in this case based on those reasons that I've mentioned earlier. The two serological tests we would like to do, usually I would like to do rheumatoid factor and anticyclic citrullinated peptide protein. Two of them are serological tests that can be done to confirm a patient that has rheumatoid arthritis. Classification of DMARDs, I saw this table. The DMARDs can be classified as either synthetic or biological. Even on the synthetic, under synthetic, we will have immunomodulators also. The synthetic, the common ones we use is methotrexate. Is commonly used. Hydroxychloroquine also is there. Sulfasalazine, leflunomide, they are all common drugs that synthetic DMARDs, disease-modifying anti-rheumatic drugs that we can use in rheumatoid arthritis. Biological ones will be TNF alpha antagonists like etanercept, like infliximab. We have interleukin-1 antagonists also, and Akira can be used also. T-cell modulating agents like abatacept and rituximab as the lymphoid depleter. There is a new drug now, a new classification. They call it Janus kinase inhibitors. Example is perpicitinib, which was approved. It was first approved in Japan in 2019. 2019 March. South Korea too. It was approved in 2020 January, but it was recently approved by FDA in US October 2023. Last year, it's being used now as one of the drugs that can be used for rheumatoid arthritis. So briefly, I will go through just an overview of rheumatoid arthritis. It is a chronic multisystemic autoimmune disease condition with unknown etiology, and it is characterized by persistent inflammatory synovitis, usually worse in the morning and lasts for about an hour. The inflammatory comes with pain, swelling, and stiffness. And the reason why it's common in the morning because the circadian circulation of pro-inflammatory cytokines like interleukin-6 is more common in the morning. And the peripheral joints can be affected usually, and usually it is symmetrical. However, the large joints can equally be affected later. And the patient is present with painful swelling joint and stiffness, which will worsen following rest. But when the patient does some activity, the pain can actually reduce. The small joints of the hands are mostly affected, the distal interphalangeal joints, proximal interphalangeal joints. They can all be affected. Then it could have extra articular manifestation also, can affect the eyes, the skin, the lungs, the heart, the nerves, and blood also. And this thing can be seen, those extra articular can be seen about 15 to 25% of cases. And it is genetic, both the etiology is not very clear, but genetic and environmental factors combined together can play a significant role in rheumatoid arthritis. Genetic human leukocyte antigen DR4 has been detected, and smoking too, from environmental smoking, can be a risk factor. But to say that alcohol, to some extent, it could be protective. And about 1% of adults are affected in the developed world. In a center where I'm being trained there, I think they have the second, after degenerative joint disease, I think the second most common condition they see in their rheumatology clinic. Females are more affected by 2.5 times compared to male. The age of affectation is from 40 to 60 years, and they can have, when disease progresses without early intervention, they can have some deformity in the joint, like the popular cotinate deformity, which patient will have flexion at the proximal interphalangeal joint, and upper extension at the distal interphalangeal joint also. And then you can have swan neck deformity, which is reverse of the cotinate deformity by having flexion at the distal interphalangeal joint and the upper extension at the proximal interphalangeal joint. This is a picture showing a patient that has cotinate deformity. You can see at the distal interphalangeal joint, there's flexion there, and there's some extension at the proximal interphalangeal joint, there's a flexion there, but at the distal interphalangeal joint, there's some extension there. Another one shows this one leg deformity. You can see at the proximal interphalangeal joint, there's extension there, while there's flexion at the distal. At proximal, there's extension, but distal, there's a flexion there. It's extra-articular affectation could affect the lungs to give lung fibrosis. In the heart, it can cause myocardial infarction, pericarditis, endocarditis. In the blood vessel, it can cause atherosclerosis. In the brain, it can cause stroke, probably because of atherosclerosis. And they're equally prone to have hypertension because of atherosclerosis. In the blood, they can have anemia. Apart from anemia, they can equally have neutropenia, especially when Fetty syndrome is complicating it. In the skin, they can have rheumatoid nodules, and rarely they can have pyoderma gangrenosum and erythema nodosum and papilla erythema also. Kidney, many things can happen in the kidney. They can have amyloidosis. Apart from amyloidosis in the kidney, they can have glomerulonephritis also. Even the effect of the drug that they are taking can cause tubular interstitial nephritis in the kidney also. In the eyes, they can have episcleritis, keratoconjunctivitis, which can mimic Sjogren's syndrome. Neurologically, they can have peripheral neuropathy, mononeuritis complex, and carpal tunnel syndrome. The bone can have osteoporosis because they are always immobile. If it's very severe, they could be mobile, so they might be end up not being active. The teeth, they can have periodontitis also. So how do we diagnose this? The key investigation to diagnose is rheumatoid factor and anti-cyclic cetylated peptide protein. But this, in 2/3 of cases, these two serological tests could be positive, but however, it could be negative in 1/3 of cases. And if it is negative, that does not rule out rheumatoid arthritis. even it has been said that about 10% of healthy people, they can equally have rheumatoid factor that is positive. So it's not specific. Rheumatoid factor is not specific at all. But other tests that we do full blood count, which can show anemia, ESR. Usually it is raised because of active phase reactant. Renal function test will show some renal derangement. ANA could equally be done to rule out SLE. Then CRP usually is elevated because of inflammation, and liver function test also be done. So X-ray of the joint is very important to do too, which can show osteopenia. Apart from that, they can have a soft tissue swelling. I could equally have bony erosion and have subluxation. And abdominal ultrasound scan could be done to check the kidneys, whether the kidney size might be normal or even a little bit enlarged if the patient has amyloidosis. The chest X-ray has to be done also because before the patient is commenced on treatment, you have to rule out TB, but before the patient is commenced on immunosuppressant, so that not flare up the TB that was there silent before. Echocardiography to look at the heart, whether it has endocarditis, myocarditis, any of the complications in the heart. This is a diagnostic criteria. There's American College of Rheumatology and European Union League against rheumatic disease criteria of 2010, and it is categorized as this. If the patient has just one joint affectation, we score the patient 0. If there are 2 to 10 large joints, it's 1. But this priority is more on the small joints. If 1 to 3 joints are affected, you score the patient 2. If it's 4 to 10, you score 5. Serologically, if rheumatoid factor and anti-CCP are not there, it's 0. And if the duration of the symptoms is less than 6 weeks, you score 0. If it's more than 6 weeks, you score the patient to have 1. In total, if the patient has a score of greater than or equal to 6, you can consider the patient to have definitive rheumatoid arthritis. There are some cancers that can be associated with rheumatoid arthritis, especially lymphoma. They will have lymphoma complication. They can have stem cancer, but normal type. You probably have lung cancer also. Possible differential could be crystal-induced arthritis, like we have in gouty arthritis or pseudogout. Systemic lupus erythematosus or affect joint also could be a good differential. Osteoarthritis could be a good differential. Psoriatic arthritis, it could be a differential, but the patient will have more than manifestation in the skin that will suggest that the patient may have psoriatic arthritis. Then reactive arthritis, when the patient will have urethritis, he has a problem with the height, like conjunctivitis, that he call it the same. Then Lyme disease from the teeth, it could be a differential too, but the person will have some skin manifestation like a cutaneous migrants also to suggest that it's possible to be from Lyme disease. How do we manage? Management is multidisciplinary because it affects not only joint in most cases can be extra articular. So the cardiologist has to be involved if the heart is involved. Nephrology has to be involved in case the patient has renal affectation. Also, the pulmonologist has to be involved, the physiotherapist. And physiotherapy is one of the key treatment modalities. For drugs treatment, the patient has to be on anti-inflammatory drugs to relieve pain, like a short-term steroid and analgesic. Analgesic, like you can use paracetamol or NSAID if there's no contraindication. For DMARDs, you can use immunomodulators like hydroxychloroquine. You can use synthetic one like methotrexate or sulfasalazine. Then biologics equally can be used if the patient is not responding to any of those initial ones. Surgery can be done if it is indicated, like a patient that has a carpal tunnel syndrome can do synovectomy. You can do, if the joint is completely destroyed, can do joint replacement surgery also. RA in pregnancy, it's shown that most people that have RA when they are pregnant, the symptoms tend to reduce. and methotrexate and leflunomide are therapeutic, so they don't give them in pregnancy. And prednisolone, hydroxychloroquine, and sulfasalazine, they are all safe in pregnancy. The goals of treatment is to reduce pain and to reduce inflammation, as well as to slow the progression of the disease, and to equally improve the overall function status of the patient, and to prevent complications. There are some syndromes that are associated with rheumatoid arthritis, like a Kaplan's syndrome. When somebody has rheumatoid arthritis, equally has pneumoconiosis with the intrapulmonary nodules on the X-ray. And it's a Kaplan syndrome. They have Ferty syndrome. When the patient has rheumatoid arthritis, has splenomegaly, has neutropenia. I have Sjogren syndrome. When they have keratoconjunctivitis, they have dryness of other in the saliva.
Please try and round up. Please try and round up.
I'm almost done. They equally have carpal tunnel syndrome also. The vaccination has been advocated. The patient has rheumatoid arthritis and use influenza vaccine can be given yearly because they are because of they are on the immunosuppressant. They are prone to have infection, especially a pneumococcal infection. So they are it's advisable for them to have pneumococcal vaccine also. So if the patient is above 65 years of age, they can have one dose. If the patient is below 65, you can give at least 2 doses between 2 to 5 years interval. Prognosis is not very good because the disease is progressive for life. But if the person is diagnosed early and treatment is start on time, they will have a better prognosis. There are some prognostic factors that denote poor prognosis. If the patient have extraarticular manifestation, has a persistent synovitis, early erosive disease, we have positive rheumatoid factor and CCCP. There's family history also of rheumatoid arthritis. This is my last slide. Thank you for listening. Thank you, sir.
Dr. Yaya, are you there?
Dr. Yaya,
thank you, Dr. There are more contributions. We can entertain some contributions, please. Hello? Let me start with my own. Dr. Adi, thank you very much. You made mention many organs are affected in rheumatoid arthritis. It's quite sure. I remember 2017 National Postgraduate Medical Exam, Part 1. There is an essay question that say write about extra articular manifestation of rheumatoid arthritis. So actually, it's common to have extra articular manifestation. However, the lungs, you mentioned only lung fibrosis. There are a lot of things, I think more than 10 things that can occur in the lungs, ranging from pleural effusion, yes, lung fibrosis, especially in the lower lung zones. They could also have bronchiectasis. It's one of the risk factors for bronchiectasis. Pleural thickening can be seen, fibrosing alveolitis. Then, as you said, Kaplan syndrome, again, in a co-worker's lung, if they have intrapulmonary nodules, they can have. Then infections. TB is a known infection known to occur in the setting of RA, both because of the disease and use of the mats. And that's why before somebody is given the mats, it's advocated, like in our center, we're in the same center, the rheumatologists used to screen patients for TB because they are known to have high risks of development of TB in some cases. So these are my contribution. Thank you. Well done. It's a lucid presentation. So we entertained some contribution before our teachers came coming. So any more contributions, please? Maybe Chief Dr. Christabel can take over.
Okay, Dr. Yaya, thank you. Thank you so much. Dr. Lawrence, Dr. Adeyeye, thank you so much for your lucid presentation. It was a good one. I guess that's why nobody has comments. Dr. Yaya, your comments too are well noted. I think that's a very vital contribution. Thank you so much. Please, I don't know, National seem to love rheumatoid arthritis, leprosy, they might have changed, but just have it in mind that those two topics, I don't know, they seem to love it. So just make sure you have fine details of those topics. I think that's that. Thank you everyone for coming to class, our facilitators. Thank you. We appreciate your presence, your sacrifices. Congratulations to our